All right, thank you, everybody. Monica, thank you for that wonderful lead up. I appreciate all of it, except for the picture of me that you must have found on the internet with my double chin, but I'll go with it nonetheless. So thanks, everybody, for joining us today. It's a weird time, and I think through weird time comes innovations. And so here we are doing virtual webinars to discuss important topics with SAGES. But SAGES is doing a great job in helping this event work. So thanks to everybody. So Aesculap has done a lot to move forward with minimally invasive surgery, which is probably the one intervention that we can make as surgeons to decrease our narcotic utilization in our patients. But we have a lot of opportunity out there that I'd like to discuss today. So in my practice in Dallas, I am a general and bariatric surgeon, 2/3 of which is bariatrics, 1/3 is general. And I've been doing MIS surgery for now 11 years. And so my practice has been pretty stable. We were using narcotics for a long time, and our standard pain regimen was T3s or hydrocodone or what have you. But I really had an opening or awakening when a year and a half ago, I had a loved one who had an elective surgery, an operation that I would often do, but I didn't do it on my loved one, of course. And they recovered from surgery without the use of any opioids at all. And it made me question my own practice, because had that been my patient, we would have done things quite differently. And their protocols made me investigate as to whether my protocols should be adjusted. And over the next few weeks, I did small changes with different patients, and I found that really I could control my patient's pain without any opioids post-op in the majority of my patients. And so in our practice, we've basically completely eliminated opioid use, and to our surprise, our patients are relieved and refreshed for the most part that we're not prescribing opioids. And of course, there's always an exception, but I was surprised to see that our patients are happy with our initiatives. So let me just make sure I can advance slides. Okay, so our agenda today is as follows. We have basically 4 points or headings that we want to hit. Acknowledge the scope of the problem. I like the word scope. It's MIS surgery, SAGES, of course. But acknowledge the scope of the problem. Opioids are around. They've been around. They will continue to be around. But opioid abuse and addiction and overdoses are on the rise. We're going to go through what are opiates and actually what is pain, because although it seems really straightforward, pain is much more than we may initially think it is. We're going to discuss some of the effects that opioids have on physiology, on recovery after surgery, and the relationship between short-term prescriptions and long-term addiction. And there is a relationship there. It's something that I was unaware of until I really started doing my own research. And then lastly, present some of the current data and trends, both in the US and worldwide, and how our multimodal approach has really helped our patients recover from surgery. So we need to look at the nature of the epidemic, and this graph is from the CDC website, actually, and you can see that this the wave of the epidemic of opioids has basically 3 different categories. We have our commonly prescribed opioids, your natural and semi-synthetics. You have our heroin, which of course none of us are prescribing. And then our other synthetic opioids, and that's like tramadol and fentanyl or other prescribed opioids. And so there are basically 3 waves in this. The first wave began with increased prescriptions written in the 1990s, and we started to see overdoses in significant numbers by the late 90s. The second wave began in 2010, and that was overdoses related in part mostly to heroin. But paralleling that wave in 2013, we have our overdoses related to synthetic opioids, and those are largely fentanyl. And so as things have moved forward, we see that our synthetic opioids are actually causing the most number of deaths in our country. And these are deaths per 100,000 people on the y-axis there. And the other thing to note is that commonly prescribed opioids are relatively stable. And so, that's stable despite MIS surgery being used more and more prolifically. So as MIS surgery has gone up, our prescription patterns haven't really changed too much, unfortunately. And so what we know from all of this is that we as physicians are part of the problem here. In Texas, our prescriptions are tracked through the PMP, the Prescription Monitoring Program. Every time I write for a narcotic or an opioid, it's tracked, it's documented. And I'm actually required by law, and I'm not sure how it is in your states, but I'm required by law to check the database on every patient before I prescribe a narcotic to see if they're getting narcotics elsewhere as well. And then as of April of this year, the Texas Medical Board requires for my license that I do 2 hours of CME related to opioids every year. And so this is not a fad, this is here to stay. And the greater emphasis on this will continue to grow throughout the country, I'm sure. So opioids and narcotics are effectively two words for the same thing. Narcotics, if you're El Chapo, you're selling narcotics. If you're Dr. Delgante here, who was known as the Candyman and ran a narcotic pill mill in New Jersey, then you call them opioids for the large part. And so opioids and narcotics are technically the same thing. Well, where do they come from? You know, opium has a very long history. It comes from the dried latex from the seeds of the opium poppy or the opium flower. 12% of that latex is actually morphine, and that can be processed to produce heroin and other synthetic opioids for medicinal use that may be used in the illegal drug trade. The latex also contains other related opiates, so those might be codeine, thebaine, and papaverine. So the process of extracting the opium involves actually quite a bit of labor, and so you have to scratch the latex off of the flower pod, manual labor to get the latex to leak out, which is then dried, gives you a sticky residue that can then be processed. And since ancient times, the process hasn't changed. The other thing that's really quite interesting is that the production of opioid is only on the rise. So 80% of Afghanistan is rural countryside, and that rural countryside is used in large part for opium. In fact, up to 30% of the GDP of Afghanistan is dependent upon opium. And so the opium poppy harvest produces more than 90% of the heroin globally and more than 95% of all of the opium that makes its way to Europe. If you look at the land mass that's used for opium in Afghanistan, it's more than the land mass of the coca bean in all of Latin America. And so this is a huge product that's being made in Afghanistan. So initially, in the early 2000s, the Taliban actually put a moratorium on this and production went down, but production has since gone up considerably. And so if you look back at the numbers, these are DEA statistics. In 2002, Afghanistan produced 1,278 tons of oven-dried opium. The following year, 2003, that number doubled, and in 2004, it doubled once again. And the numbers have effectively been stable since then. So right now, we estimate that 6,000 metric tons of opium leaves Afghanistan every year. That 6,000 metric tons is valued at $3.5 billion, of which 700 million belongs to the farmers of Afghanistan. And so the only point in me really pointing this out is that this is not just a medical issue, this is a political issue, this is a financial issue, and really is affecting the entire world. So what is pain? And it seems a little bit funny that I'm trying to define pain for you, but pain actually has a definition, and this is as defined by the International Association for the Study of Pain. That's an organization I was unfamiliar with up until recently. And the definition of pain involves sensory, emotional, and cognitive experiences. And that may be related to actual or potential tissue damage. And if you understand these three components of pain, then you may have a better understanding about how to treat it. So it's much more than just the trauma that we impose on our patients through surgery. Through surgery, you know, we have We may be cutting, we may be sewing, maybe implanting mesh, what have you. But the actual components of pain are more than sensory. They're cognitive and they're emotional. And the three of these components come together to give what we call what the patient calls their pain experience. And I think as surgeons, we want to talk about the sensory component. We think about the sensory component as we made an incision, we caused pain, but there's more to it than that. So pain is defined through a couple of different components here. It's a personal experience, and that personal experience may be influenced by biological factors. We know that redheads typically have more pain than others, psychological factors, and social factors. And it's not just the pain traveling along the neurons. It's not just nociception that causes our patients to say that they have 3 out of 5 pain or 7 out of 10 pain. And so the pain that they are quote unquote feeling cannot be inferred solely from the activity of these sensory neurons. Additionally, through their life experiences, we learn what the concept of pain is. If you have young children, you know this. Your young child may fall or get hurt, and before they even start crying, they look to their parents to ask, is it okay if this hurts? Is it okay if I cry? And as a parent, we can often modulate that response by telling them it's okay before they cry, and then they, quote, don't have pain. They had the same injury. And so life experience teaches them what pain is. But nonetheless, we have to respect what our patients are telling us. If they hurt, we have to treat their pain. But again, pain is not just the sensory component of pain. It may be the emotional or the cognitive component as well. So pain may also serve an adaptive role. By being in pain, a patient may have a caregiver that expresses concern for them. Someone may be paying more attention to them if they have pain. And although they may not be intentionally trying to get that attention, having pain gets them that attention, and that may contribute to the amount of pain that they are experiencing. So certainly as surgeons, we worry most about acute pain. That's what we cause our patients through the course of doing surgery. But one thing that we may not be paying enough attention to is the evolution of this acute pain into chronic pain. So acute pain is typically defined as pain less than 3 months. But as that pain goes beyond the 3-month mark, that evolves into chronic pain. And so what started off as a symptom can become a disease. And if we are treating that acute pain with opioids, we may be creating other problems, because opioid utilization has not just sensory effects, but has emotional and cognitive effects on our patients. So the tissue trauma wears off, but the opioids that we've been giving them stimulates the other components of the pain trifecta. And if those are not properly managed, now we can turn into a chronic pain picture. And I'm going to try to explain what that means here in a moment. So these are 2 pie charts that show the contribution of tissue damage or tissue input for both acute and chronic pain. You can see that in the acute setting, certainly tissue input has the greatest influence on acute pain. So 2/3 of that input is roughly due to the incisions that we made, or the operation that we did, or the mesh that we implanted. But 1/3 of that is actually emotional or cognitive components. And so those are parts that maybe can be manipulated such that the overall pain is reduced. But with time, as the tissue trauma wears off and as things heal, the tissue trauma component reduces dramatically. So 1/6, 1/7 of the tissue of the total pain in the chronic pain situation is related to tissue damage, whereas the rest of it is thoughts and emotions. And the opioids that we've been giving to them contribute to those thoughts and emotions. And so when you have a surgical patient, part of our obligation is to control their acute pain, and the other part is to limit the possibility of chronic pain. So we know that our brain is very good at manipulating subjective information, and it'll do this to fit into the context of its surroundings. And so you look at these 2 squares, square A and square B, and clearly those are different color grays. And our brain tells us they're different colors because of the context around it. And so if a patient is expecting to have pain, they may feel more pain after surgery, and they may allow the emotional or allow the cognitive components of that pain to tell them what they should feel. But as the context changes, as the surroundings may change, those two squares now approach the same color. And you can test this by cutting out those two colors from a screenshot or whatever beforehand. And you'll see if you cut out A and B beforehand, you put them next to each other, they really were actually the same gray. And so, in other words, the context really matters. And this is known as lightness constancy in the psychological world. But if patients expect to feel pain, they may feel pain. And if they expect not to feel pain, they may not have as much pain. So all addictive substances work on the brain, and they work through dopamine release. We know that dopamine release makes us happy. It makes us feel good. And so all of the things that we do in life that we enjoy may cause dopamine release and can be addictive. And that's true of opioids, alcohol, THC, cocaine, um, amphetamines, nicotine, LSD, gambling, sex, what have you. And so ultimately, the dopamine response is what creates the addiction. I'm not sure if you can hear this. Hopefully you can hear my voice over it as well. But you remember from Wizard of Oz, they're running through the field of poppies, and those are actually poppy flowers, towards their hopes and their dreams, right? They're running towards the Emerald City, where all good things can be accomplished. This is our success system. But opium is very good at making you feel like your short-term goals are closer than they actually are. You feel a sense of reward, your depression, anxiety may go away. You actually get a warm-like feeling. But too much opium, too much poppy, and our biology takes over. And the endorphins that we once felt go away. We become dependent on external endorphins. And then our respiratory suppression takes over. And so we have a good feeling, and then we suddenly have no feeling. And just like in Wizard of Oz, the Dorothy and the lion were subject to biology and physiology, and so they went down from too much opium. But the Tin Man and the Scarecrow, they were okay. So opioids in the immediate postoperative period can cause some significant issues, some of which we may not recognize unless you really delve into the data. Clearly, we know that patients can get confused because of narcotics, which can obviously delay recovery. Medical costs may go up. Opioid hyperalgesia can happen where you have increasing requirements for narcotics as they're on it longer and longer. More than 7 days of opioids increases the possibility of disability. Patients are more likely to fall or get injured because they're on opioids. And then the other funny things is if you look at age-matched controls, opioids actually increase the risk of an MI by threefold, and the risk of GI bleeding associated with them is the same as non-selective NSAIDs. And so those are things that certainly bother us as surgeons if our patients are having postoperative issues, and they may be in part related to opioids. So based on the CDC guidelines for opioid prescribing for chronic pain, the literature to support chronic opioid use is very limited. But there is an increased risk for harm with long-term use. And interestingly enough, early opioid prescribing patterns can be predictive of long-term opioid abuse. So you can see here with these graphs, the longer that someone is given an initial prescription for, the higher the likelihood they will still be on opioids at 1 and 3 years. The dashed chart shows you the likelihood they're still on opioids at 3 years, and the continuous line is at 1 year. And this was done by giving cancer-free adults a prescription for opioids for pain relief and following them over time based on how long that prescription was given for and how many morphine milligram equivalents they were given. And so what they found is that the sharpest increases in chronic opioid use were observed after the 5th day and then the 31st day on therapy. Additionally, second refills were associated with chronic long-term use. More than 700 morphine milligram equivalents was also associated with long-term use, and the initial supply of 10 or 30 days was also associated. The highest probability of continued opioid use at 1 and 3 years was observed in patients who started on a long-acting opioid, followed by patients who were started on tramadol. So in this study, they showed that 1 day of opioids, or I'm sorry, 1 initial prescription of opioids can render a 6% risk of still being on them at a year. After 8 days, it's up to 13%, and after 31 days, it's up to 30% chance of still being on them at 1 year. And so we as physicians who are writing for these opioids have an obligation to limit the possibility that we're not creating our patients a long-term addiction problem. I think someone's microphone is still on. If you can check it and mute it, please. This was a recent publication that you may have seen published either in literature. I know it was also on some of the Facebook surgery forums. This was published by Dr. Carafani, Annals of Surgery, just a few months ago. And they looked at 16-year-olds and older undergoing appendectomy, gallbladder surgery, or inguinal hernia repair. They looked at 14 hospitals across 8 countries. This was a review of medical records. And they looked at their preoperative, intraoperative, and postoperative characteristics. There were almost 5,000 patients involved, almost half of which were women. Mean age was around 50, and 4% were on opioids previously. And basically what we found is that here in the United States, we prescribe a lot of opioids, a lot of narcotics. And so our patients are getting 23 pills versus 1 pill elsewhere in the world. And 9 out of 10 patients were getting prescriptions for opioids, whereas elsewhere it's 1 out of 20. So I think that this tells us that the rest of the world can do it, and we can probably do it as well. This was a non-inferiority study published in JACS just last year. It was a prospective study looking at how they could implement a new protocol for their pain regimen postoperatively in their open inguinal and lap chole patients. They want to implement a multimodal intra and postoperative analgesia bundle, and they were promoting co-analgesia, so 2 or more agents. They were trying to reduce their opioid prescriptions, and they wanted to see how their patients did and how their perceptions were of their quality of care. And you can see that their intervention happened when the blue line turns to red. On the y-axis, you have your total oral morphine equivalents. And they were able to, by having a standard regimen in place and by using NSAIDs and acetaminophen, they were able to virtually eliminate opioid use in the vast majority of their patients while treating pain and while actually having improved patient satisfaction scores. The other thing to be kind of aware of, it's really quite interesting, right now in our pandemic, opioid overdoses are up. They're up quite a bit. And this is coming out of especially some of the big cities. I know there's been reports that of New York and Chicago. And so these deaths that we're seeing overdose deaths from COVID-19 restrictions are significant. And so we think that some of the closures and restrictions and inability for people to go to some of the recovery centers and substance abuse centers have led to some of this, but there's other things going on as well. We don't really know the whole story with this pandemic by any means, but from March to May, alcohol sales were up 25%. A review of 500,000 urine drug screens showed that the use of non-prescribed fentanyl was up by 32%, methamphetamines up by 20%, and cocaine up by 10%. And the American Medical Association has also come out, and they've said that they're greatly concerned because of the increased numbers of opioid-related deaths around the country. And this has been reported in at least 35 states. So who's most affected? It tends to be our younger patients with death rates doubling over the last year. Younger patients over the weekends tend to have higher rates of overdoses. And these may be in part due to the unintended consequences of social isolation, social distancing during this outbreak. Additionally, boredom and loneliness can be triggers for addiction. And additional stressors or job losses with decreased income could cause people who have addictive personalities or addictive disorders to relapse back into substance abuse. So other risk factors are people who have once been institutionalized or in correctional facilities. So those are the things to certainly watch out for. And for the most part, those may not be the patients that you typically care for, but recognizing that the prescriptions that you're giving our patients may end up being abused in today's setting is important. The other thing to consider is a lot of the orthopedic surgery, the neurosurgical issues have been delayed. And so patients for their chronic back pain, hip pain, knee pain may be getting narcotics or may have access to narcotics that they didn't previously have. So I think most of us in general surgery are operating again. Bariatric surgery, we're operating again. But considering the fact that your elective hernia, your elective gallbladder, your sleeve, what have you, is now going home to a socially isolated state, or may have risk factors or may be alone, and now you're enabling them with narcotics, is something to consider. So it's important to understand the efficacy of pain medications. This was from a Cochrane review. Certainly, the big thing here is oxycodone is very potent, but potency should not be confused with efficacy. On the y-axis, we have the percentage of patients that showed a 50% improvement in their pain. So oxycodone 15 milligrams actually gives you the least improvement in your pain in the acute setting. So when you start doing multimodal therapies, that's when you start to see the greatest benefit. But even individually, you see that ibuprofen 200 milligrams does better for 50% pain reduction than oxycodone. Ibuprofen 400 milligrams does better than 200 milligrams. And you add ibuprofen and acetaminophen together, gives you the best results. So multimodal therapy, non-opioid analgesia may be favored from an efficacy perspective over your opioids. The CDC has its guidelines. CDC has some recommendations for how we should be managing pain. We know that undertreatment of pain has been linked to reduced quality of life. Undertreatment of pain has also been linked to surgical complications, prolonged rehabilitation, and even the development of chronic pain. So this is a little bit of a Goldilocks phenomena. We want to try our non-opioid therapies first. And we don't want to give them too little opioids, but we certainly don't want to give them too much. Multiple studies have shown that when patients are prescribed opioids, oftentimes they don't complete the whole course initially. And so when we're giving them, we're probably giving them too much up front. And that can raise the risk of a family member overdosing on those opioids by 44% because now it's in the house. Lastly, perioperative opioid prescribing is associated with persistent opioid use after surgery. And I highlighted that on a previous graph, but the risk of them being on opioids at 1 year may be as high as 6%. And that goes up with larger prescription amounts, highlighting the risk that the risk of being addicted long-term goes well beyond the initial period. And they're not asking you, they're not asking me for those narcotics. They're asking their primary care. They're seeking their opioids out somewhere else. So the CDC has published their treatment recommendations. Our patients have been broken down into 3 categories: type 1, type 2, type 3. This is based on the BRE Collaborative and Washington State Agency Medical Directors Group prescribing opioids for postoperative pain. Yes, that's a mouthful. In my estimation, this is a little bit too liberal with their willingness to give narcotics, at least as compared with how my patients are doing. We certainly don't have to give as many narcotics as they indicate here. So for those of us who are doing minimally invasive surgery, this is probably a little bit more liberal than necessary with narcotics. But in principle, we have our type 1, type 2, type 3 patients. Our type 1s are our straightforward outpatients, lap appies or inguinal hernias. Type 2 are colon resections that may stay in the hospital for 2 or 3 days. And then type 3 are a longer term recovery. Certainly, mainstay of all of this is non-opioids first. So start them with your NSAIDs and your acetaminophen as much as you can. If opioids are necessary, you want to give short-acting opioids, and you want to give them for short periods of time. So avoiding the long-acting ones is favored. So the short-acting ones, or your hydrocodone, is preferred over your long-acting ones, such as OxyContin. So I'm here to hopefully suggest a way forward. And like I said at the start of this, I had my epiphany when I had a loved one have surgery, and I wanted to change my mindset, my way of taking care of my patients. And so working with a whole team is important. For us, it starts in the office. Our office staff need to know how to cancel our patients, how to triage them after surgery when they're calling for pain, and then bringing them in as necessary. So my patients at their preoperative appointment, I talk to them about my expectations for their postoperative pain, my hopes for them, our goals to minimize or eliminate narcotic use. And I tell them that if you're having severe pain after surgery, I have to question as to whether there's a complication that we're dealing with, and I may want to bring you in before we prescribe narcotics to make sure there's nothing going on. I work with anesthesia to minimize narcotics that are given during surgery. They now give much more ketamine to my patients than they used to. We give a lot of intraoperative Ofaramev and or Caldolor. And then we had to work with nursing, because early on we got a lot of calls from the nurses saying, hey, your patient's having pain, I want to give morphine or what have you. And a lot of that was gas pain. And we don't want to treat gas pain with narcotics. But recognizing that our nurses are there taking the patient complaints first. And so working with them required that, I went to a few shift changes at 6 o'clock in the morning to talk to the nurses about our goals and our protocols, and encouraging ambulation and simethicone and heating pads to help get them through. So getting everybody on board is imperative. So I tell them that I don't want them to have a lot of pain, but I tell them that I do expect them to be sore. And if they're having spikes in pain, then we have to figure out what's going on. Maybe they need a little bit of Robaxin or something, but our goal is to avoid opioids when possible. So I send them a 7-day supply of gabapentin. We start that gabapentin 2 days before surgery. Typically it's 300 milligrams 3 times daily. I'll say that my smaller female patients often have symptoms with that much gabapentin. They may have dizziness or nausea, and so I'll write them for 100 milligrams three times a day, starting 2 days before surgery. But most patients get 300 TID starting 2 days before surgery. That leaves them 5 days worth for after surgery. In the operating room, they're getting IV Ofaramev every 6 hours, and IV Caldolor as appropriate. My gastric bypass patients don't get NSAIDs. They get that every 6 hours, and I don't actually alternate the Ofaramev and Caldolor. I give it at the same time, and that's been shown to have a greater effect. I do my own tap lock while my patients are under anesthesia. I don't give it to anesthesia to do it. I do it myself. It's very easy to do if you're not already doing your own tap locks. It's very straightforward. We encourage our patients to move early, get their heating pads, and then when they get home, they have 5 days of gabapentin. They can add ibuprofen, they can add acetaminophen as necessary. When we do this, I've had just a handful of patients in the last year that needed narcotics after surgery, or willing to come into the office to get an exam for their narcotics. Really, our narcotic utilization rate is under 10%, and that includes the patients that may get morphine in recovery, morphine on the floor after surgery. So a few notes about this. I think tramadol is sometimes perceived as a very benign medication, or interchangeably with gabapentin. I don't find that to be true. It is a mild opioid, and it does carry long-term risks. So the same risks that we see with other narcotics or opioids. And so we try to avoid the use of tramadol when possible. This is our tap lock, and so these are the planes that the ultrasound shows you when the anesthesiologist does their tap lock for us. I'll just do it in the operating room. It adds literally about a minute to the case to do both sides. So I mix 20 mLs of liposomal bupivacaine, which is the entire vial, 30 mLs with 0.25% Marcaine, so now we're at 50 mLs total. And then I mix 150 of saline. And the saline is important because the liposomal bupivacaine gets absorbed by the fat very quickly, and it needs to be diluted to distribute properly. And so I push that through an 18-gauge needle. and I do one hit high, medium, and low, all in the anterior exterior line on either side of the patient. So through all those modalities, we've done a good job of limiting our needs for narcotics. So a few closing thoughts today. Opium has been around for a long time. In fact, there are reports that opium has been actively collected since 3400 BC. So let that sit in for a second. So 5,500 years of opium are part of human history. And so we're not going to completely change that. But I think we can do some things differently. As surgeons, we create pain and we have an obligation to control it. Historically, through our training, it's been instilled on us that opioids are a mainstay of early postoperative pain. And I think that mantra needs to change. I think there are other things that we can do without the use of opioids and non-narcotic analgesia to help our patients. We should still control their pain. Changing one's practice, certainly takes people out of their comfort zone. I recognize that. I know that I'm in the minority in my approach, especially in my hospital. I'm pretty much the only one that's doing this, and so you'll be also in the minority initially in your systems as well. But your patients will appreciate it. Their families will appreciate it. The long-term likelihood of addiction will go down, and we're helping our patients. So. Thank you for listening. Thank you for your time. Please email me if there's anything I can do for you. Thank you to Aesculap for allowing this to happen today and for providing the platform for me to speak about this. And I will say that if this excites you, if this is something that you want to be a part of, there are some of us that are working on pushing this at a national level. If you want to be a leader in your hospital, in your community, I can help you with that. We have social media things that we're working on. So please, and actually the national media is starting to pick up a little bit of it as well. So if you're interested in this, please reach out to me. There's my email above. But thank you very much for your time. Thank you for Sages. Thank you, Aesculap. And everybody have a good day. And I'm here to answer any questions that pop up. Thank you very much.